Good morning, everybody, and thanks particularly to Alison and PCFA for asking me to update you today on some of the information in regards to familial aspects of prostate and ovarian cancer. I'm a genetic counsellor, so I see families who have family histories of cancer and want to know if there could be some sort of genetic predisposition. And I suppose at the moment we're dealing with what we call the Angelina Jolie effect. I'm sure... And actually it's a really good way of connecting with people because everybody knows about Angelina Jolie and what's happened to her. As a result of that, in our centre, our calls and inquiries and referrals have gone up by about 150%. So it's actually a great awareness of the genetic aspects, particularly of ovarian cancer, and also today I'm going to talk to you about the genetic aspects of prostate cancer. So I thought I'd start with prostate cancer first, actually. So I'm sure you're all aware that prostate cancer is a very common cancer in men, and the background risk is about 1 in 8. It's not unusual to have a family history of prostate cancer because it is such a common cancer. So if people ask me what my job's about, I actually say it's like doing a bit of a jigsaw puzzle. And so what you do is you're looking at the pieces of the puzzle, so all the people in the family who've had cancer, to see if it makes up to a picture of some sort of genetic predisposition. And it's important when you have a family history of cancer, not just to put everybody in the puzzle, because we know that cancer is a very common condition. So there are some pieces that you actually don't put in your puzzle. And prostate cancer is one of the common cancers that you have to be careful of, not to just put in your puzzle. So a family history, though, is a strong risk factor for the disease, and it indicates that inherited factors are actually quite important in prostate cancer. So prostate cancer can be explained by what we call single genes, like what Angelina Jolie's got, BRCA1 she's got, but there's another gene that's more associated with prostate cancer called BRCA2, and I'll tell you a little bit more about that. There's a lot of new work going on in genetics in regards to what we call common genetic variants, and I'll tell you a little bit about those too. So if we go on to the single gene, so what I mean by a single gene is that if you're a person who inherits that gene, have a high risk of developing, if we talk about BRCA1 and 2, you have a high risk if you're a woman of developing breast and ovarian cancer, and if you're a man, you have a higher risk of developing prostate cancer. So men with BRCA2 mutations are known to be at a 5 to 7 times increased risk of developing prostate cancer, which is significantly higher than the average man. The risk of prostate cancer with BRCA1 is less clear, but it is thought that there is a slight increase in risk, and that could be double the population risk. We also know that there's a quite strong emerging research studies showing that men who have BRCA2, who inherit a BRCA2 mutation, if they do develop prostate cancer, it's often a more aggressive disease and the survival outcome is worse. So it's really important to identify men who might carry a BRCA2 mutation so that screening can be undertaken to detect a prostate cancer at an early stage. So in thinking about that, what sort of research projects are there for men who carry BRCA2 mutations? There is a big project, an international project that we're quite heavily involved with called IMPACT. There are a lot of countries in the world contributing to this study. It's an international study to evaluate the role of targeted prostate cancer screening in men who are BRCA2 1 and 2 carriers, and there's also controls in that as well. So far there's over 300 men who've been recruited, and in Australia we have the second highest recruitment rate. So I think that says a lot for the men who are BRCA2 carriers, that they really wish to do something not only for themselves but their families. And the preliminary data is actually showing some good signs. I'm no expert on PSA testing, I can tell you that, and I know there's a lot of controversy about it. But what it's showing is that PSA is actually a very good test to be using in men who are BRCA2 carriers. So whilst there's a lot of controversy about using PSA as a test in the general population, the results are showing that it's actually quite a good test for these men. So these results are supporting that we continue screening men in this way, so using PSA as a good screening tool. Okay, common genetic variants. Basically, I'll give you a bit of a genetic 101. Basically, the reason we don't all look the same in this room this morning is that our DNA has slight variations in it. And that's really good that we don't all look the same or behave the same. And so we have what we call these common genetic variants, which in themselves cause a slight increase in risk for many types of cancer. And with prostate cancer, there's been about 70 of these common genetic variants detected to date. And what we know is that the more of these variants that you inherit, the more your risk goes up. So say you have 6 variants and each is worth a factor of 2. If you just inherit 1, then your risk is only 2. If you inherit 4, your risk is 8. And so it goes on like that. And this is, I think, where a lot of the future is going in regards to genetics. In ovarian cancer, in breast cancer, in prostate cancer. And as I said, you can see that to date, over 70 of these, we call them SNPs, 70 of these SNPs have been identified for prostate cancer. So where does that then take us? That takes us to actually thinking about how can we use this genetic information and how can we use this SNP information in identifying men who might have a higher risk of prostate cancer than, say, the average man, and also men who might have a lower risk of prostate cancer than the average man. So this information is going to be really helpful for us in the future. And what we've seen is that men who have the top 1% of what we call these SNPs, and we call them in the high risk group, have about a 4.4 times greater than the average risk. So that's significant enough to warrant doing screening in. And basically where this will take us is that we'll be able to, as I said, identify men who have an increased risk and also then provide screening for them so that we can either detect it very early and then go on to clinical trials and look at treatment for men with prostate cancer. I suppose another thing to think about is how do we use prostate cancer when we're looking at our jigsaw puzzle in putting family histories together. And unfortunately at the moment we don't use prostate cancer probably as much as we will in the next 2 to 5 years. We don't use prostate cancer as a marker for how we select families for genetic testing at the moment. But I'll show you a project that we have done looking at ovarian cancer and just showing how the results of that project have changed the way we think about selecting people for genetic testing. And I think we really will be watching this space for prostate cancer because we will be using it as a marker in regards to how we select families for genetic testing. So now I'm going to just talk about familial ovarian cancer. So we know that BRCA1 and BRCA2 account for most families who have a strong history of breast and ovarian cancer. And we also know that there's another genetic condition called Lynch syndrome, where the lifetime risks for women who inherit a gene for Lynch syndrome for ovarian cancer are about 7 to 13%. Most people with Lynch syndrome predominantly get bowel cancer, but there are lots of other cancers associated, and ovarian cancer is one of them. And you can see that the mean age for a woman who develops ovarian cancer who has Lynch syndrome is much younger, so 41 to 49 years, than for a woman who develops regular ovarian cancer. That's 60 to 65 years. So you can see in these families that have a genetic predisposition, they often develop cancers at a much younger age. And so that's one of the factors that we think about when we put our jigsaw puzzle together. We look at how old are the people when they get cancer. And as I said, often you'll see in these families that people get cancer at a much younger age. So I just want to tell you a little bit about a study called the Australian Ovarian Cancer Study. We recruited women all throughout Australia who had an invasive ovarian cancer between 2002 and 2006, and that was over 1,000 women throughout Australia. And in a small study, what we did was we actually did BRCA1 and 2 testing in the 1,000 women to look to see how many women carried one of these gene alterations. And what had previously been suggested was that only 3 to 5% of women who developed ovarian cancer would carry one of these mutations. But we found that that rate in Australia was much higher. So what we found was that 14% of Australian women who have an invasive ovarian cancer actually carry a BRCA1 or 2 mutation. And that was a very significant finding. because, as I said, the previous estimates are only 3 to 5%. And I'll now demonstrate to you how that translates into clinical practice to show you that these research findings are really important, because we then take them and use them in the clinic. And that means that we use them in regards to families that we see who come forward with inquiries about their family history. There was another very important finding from this study, is that women whose ovarian tumours have what we call a BRCA pathway deficiency are more likely to have a sensitivity to platinum, which is a chemotherapeutic agent. So this study has also had very important implications in how women who are known to carry these genes will be treated. So basically what this means in practice, both not only in Australia, this has been quite a revolutionary study, what it means in Australia and internationally is that all women with invasive epithelial ovarian cancer, whether they've got a family history or not, should be offered a BRCA1 or 2 test, because 14% of them will carry a mutation. Now, why is that important? It's important because it may change their treatment, and that's of utmost importance. It's also important because then you can identify women in the family, like the Angelina Jolies of this world, who have a high risk of ovarian cancer, who can then have their ovaries removed to actually reduce the risk of them ever developing ovarian cancer. And we know that the screening for ovarian cancer is not good. So it's really important to identify these women and actually talk to them about having their ovaries and fallopian tubes removed after they've finished having their family, and preferably before they go into menopause. And as I said before, we know that the chemotherapy options for women who are BRCA1 and 2 carriers will actually be different. And that could actually prolong their life, and that's very important. And it will also allow them access to particular clinical trials. So where we go in future with the AOCS, we've got over 1,000 samples from women. We're now going to go on and test them for a whole other panel of genes, and one of those will be Lynch syndrome, because we want to understand how many women with ovarian cancer develop ovarian cancer because they've inherited a gene for Lynch syndrome. And that's really important too, because it could then again change treatment options for women. Okay, I just want to talk a little bit about psychosocial research, because it's always really important and something that's very dear to my heart. So basically what happened in the AOCS project, and what happens with big genetic research projects now, is that there is this ethical duty to return information to people. So the women who had genetic testing in AOCS, where we found a BRCA1 or 2 mutation, we then contacted them by letter and we told them that we had found something. And for many people, that was a great surprise. So I suppose just thinking about, for people who are here today who are consumers, you may participate in research studies, and you may actually at some stage receive a notification to say there's information that's come from this research study, and would you like to know that? And then you have to make the decision about whether you'd like to know. And so what I did was I interviewed a whole lot of people from the AOCS study who received these letters to find out what they felt about receiving such a letter, because we don't know much about that. Basically what we know in the literature is that people say they want feedback, but what people say and what they actually do is somewhat different. We're all fairly inconsistent beings. And there was mixed emotion. There's been mixed emotional responses to people getting these letters. Some people are really pleased and some people are less pleased, let me tell you. And the reason we let people know is that so they can act on the information. Because if you're talking about an inherited condition in your family, you're talking about other people who could be at risk, like brothers, sisters and children. So we're notifying you that there is a genetic risk in your family and it's possible for you to do something about it. But what we know is that only about 50% of people who get these letters actually then follow them up. And we wonder why. So basically what we did was we did this study, and we wanted to look at things that were acting as barriers, and we wanted to look at things that were acting as what we call enablers to people following up this information. And I just want to show you some quotes from some of the people that we interviewed. So people had very positive and negative responses into receiving these letters. The worst response was from a woman who said, when I asked her, what did you do with the letter? She said, I tore it up and put it in the bin, and then I got it out and stuck it all back together again. So again, people don't have sort of one or the other. They can have mixed responses. So you can see this lady said she was about 80. She said, I was probably quite pleased because they realised there was some connection there and that will help my family. And I think for most people that's very much what they want to do, is actually help their family. Helen actually said, I found the letter a bit confronting and a bit scary, because when you read the letter it is pretty obvious what's going on. One of the things that we found was that women's experience, so daughters whose mother had had ovarian cancer, watching their mother through that disease and sometimes through their death, really had a very lasting impact, and was really very much the prevalent story in how they thought about this. So Emma said, I was really relieved to know that I could go and get a genetic test, as a lot of people with ovarian cancer don't have that opportunity. It just gets sort of sprung upon them and it's too late to do anything about it because it's so far advanced, like it was for my mother. And those quotes are very powerful in the sense of how people are thinking about this. And you can also see Helen, who was only 28, knowing what my mum went through when she found out that she had it. She was at stage 3, so she was pretty much not much hope. And maybe I'm hesitant in finding out the results in case there's a big genetic link. So you can see some people are quite scared, whereas other people are quite relieved, and some people are both. One of the big things, as I talked about, I'm just about to finish, is this notion of familial obligation, which is something that we all feel, that we want to do the best for our families. And this was a very prevalent theme in why people followed up the letters. So Minnie says, I feel like I'm doing this for her more than for myself, and her is her mother who died from ovarian cancer. If it was left up to me, I don't know that I'd worry about it. If Mum was here, she'd like to know any findings, and she wanted to know about her family. I think that's what's influencing me to actually go and find out. So she felt a duty to her mother to go and do that. So duty and responsibility are very strong motivators for people following up this information. So just in conclusion, I just wanted to say that the genetic contribution to ovarian cancer and prostate cancer is being widely researched, both in Australia and overseas. There's an enormous amount of research being done, and I think in the next 2 to 5 years we're going to see really major advances in the way we use genetics in regards to identifying people who have an increased risk of ovarian and prostate cancer, and also treating people. And what this will do, it will enable us to identify people who have an increased risk or who are at risk of getting more aggressive disease and treat them differently. So it's actually what we call stratification of risk, so identifying people who've got a high risk and then acting differently. And that will ultimately allow for better treatment. So thank you, and I'm happy to take questions.
Fantastic. Thank you very, very much.
I just wanted to pick up from Marianne. So Marianne and I work work together on a program. So there's a program in Victoria where the geneticists talk to the wet lab. We're hardcore wet lab researchers. We work at Monash, many of us are here, and it speaks to the issue of collaboration and exchange of information and the involvement of the patients. So normally Marianne and I and people like us wouldn't necessarily be in the same room working together, but there's a program called Captive in Victoria that's funded till the end of the year by the state government. And what it has done has actually got us working together and work in a continuum. So Marianne is at the beginning dealing with the patients and the genetic counselling. And we then take the patient tissues and we take them into our research laboratories and we grow them in mice. We call these mice avatars, and you might have seen some publicity about that last week. And so these mice are running around with bits of the BRCA-X prostate cancer tissue in them. Now, why would you do that? It speaks to the issue that Marianne finished on, is how do we get better treatments for these men, and how do we know what are going to be the better drugs and the drugs that they're going to respond to? So now the mice that are running around with the bits of tissue can now be tested with the current therapies and the new and emerging therapies, and we can see whether the patient tissues will actually then respond better to a particular drug rather than another one. So it's a very good example of how people from different institutions, different disciplines, are actually tackling the same problem of how do you actually better treat these men with the familial prostate cancer.
Cool. Thank you, Gail. Yeah, give a cheer even if you feel like it. So who's got a question? You've all sort of been chatting, so let me come over with the microphone because I'll go this way and sneak through. Excuse me. Should I chuck it at you? Do you reckon you can catch it? No? What footy team do you go for? Yeah, from what you've just said, probably you'd be a Melbourne supporter.
I don't know how many in Melbourne actually listened to a very detailed interview on 3LO during the week. A big study's been resulted from looking at twins. And it was looking at, well, if twins have inherited genes, why don't they all die at the same time with the same thing? And what's coming out is very rarely do they do that. So the proposition was put up, and the question I'm throwing to you is, just having the gene seems to be a low probability of actually getting whatever it's supposed to give you. So I was really throwing, the proposition put forward by this gentleman was the inherited gene is less important than your life factors.
Good question. That's called epigenetics. Yes. And what epigenetics is about, I'm no expert in epigenetics, but I'm learning, is that the environment that you grow up in, and that includes the environment that you grow up in when you're an unborn baby, so even the fetus, and then following that, the environment in which you grow up in when you're on this planet, can influence your genes. That's what that's about. I think, with these genes like BRCA1 and BRCA2, so if I tell you about the risks, a woman who inherits a BRCA1 gene has somewhere between about a 60 to 80% lifetime risk of getting breast cancer. Now that's pretty high. And we don't know of any factors that are external in our environment that can significantly alter that risk. Okay, so we can't take that risk from, say, 60% to 20% by telling that woman to, not eat broccoli or something like that. We just don't have that information. We're learning about it, but I'm not sure in our lifetime that we'll ever have that specific information where we can actually say to someone, like a man who's inherited a BRCA2 mutation, don't do this because that's going to increase your risk. But they are important factors.
Cool. We've got one. Oh, we got an additive. Thanks, John.
Could I just embellish the epigenetic issue a little bit? Genes by themselves are just baggage. They're just DNA that's sitting in a cell, and they don't have any impact until they are expressed and turned into proteins or signaling mRNA features. And so the epigenetics is the changes in the gene environment that allow or do not allow expression of specific genes. And that's why it's so important, because the genes by themselves are just pieces of DNA. And the differences that you see between twins, which I think are a little bit less, twins actually are fairly similar in the diseases they get. They may not die at the same time, but many things are 50% concordant in twins. But the differences are due to epigenetic modifications that allow or don't allow expression of specific genes.
So now we've got time for just one. Now I know there's probably a lot more questions than we've got time for. That's why writing it down is important. So I've got the last one here. It's a quick question with hopefully a quick answer.
Hi, I understand that there are lots of reasons people might fear the impact of hearing what will come out of genetic testing. So one of them is around the discrimination that people fear once they know that, whether it's legal, insurance, whatever it is that falls from it. Can you just speak to that for a second?
I think that the issue of discrimination is not so well founded, and There's been a big study in Australia that's looked at discrimination, and basically there's not a lot of discrimination that goes on. The major issue around that the people concerned about and that we're concerned about are around protective insurances, okay? So not health insurance, not anything like that, not employment. We're not America where our health insurance is tied to our employment, okay? We're a very different country. The major insurances are income protection insurance, life insurance and those sorts of things. Now, insurance companies have always taken a family history and they've always used that information, actuaries use that information to calculate your policy. But now what they're asking for and demanding is that you provide genetic information so that they can work out your policy, which in some ways doesn't seem unfair because they're a private business, but in other ways seems very unfair. So basically what we're doing is working with the insurance industries to assist people to get policies which may not discriminate against them. Yep. But I think it's a bit overinflated at times because I think the insurance industries are being very responsible in the way they think about this and they are trying to become better educated. And that life insurance, I think it's only a third of Australians who take out a private life insurance policy. So it all has to be put into the context of what's happening in our country.